What does it feel like when you are worried there's something wrong with your health or the health of your loved one? It's scary. It is stressful. It's overwhelming. It's hard to know where to start or what to do next. That's what this panel is all about. It's about exploring ways that we can help our patients in their key moments of need by reimagining the experience of being a patient. So I'd like to start. We have an esteemed panel up here. And Jennifer, you have a long career that started on the consumer side at Procter & Gamble, where you were innovating consumer businesses. Would love to hear any of your learnings from that about creating great consumer experiences and anything you can share about how you're applying some of those learnings now in the healthcare world.
So very nice to be here. Yeah, maybe a little different than most people in this room. I didn't start in healthcare. I never thought I'd end up in healthcare. I spent 26 years at Procter & Gamble. Consumer goods company. Hopefully many of you have many of the products in your house because I still have stock, so I appreciate that. And I think, very different and yet very, very similar. But I think one of the most powerful things that I took away from my Procter experience that I've tried to bring into healthcare is, we talk about putting patients first. Procter & Gamble consumer goods are consumer-led, right? They have wants, they have needs, and the innovation model is by deeply, deeply understanding them, where are those market opportunities, what's needed, and we then would go and create what's possible, or in some instances we would acquire what's possible, but it was a pretty simple business model. Examples of things that I did when I was there on the more kind of provocative side, there was an explosion in tooth whitening. Right? It happened in your dentist's office. My team invented and created, developed, and built Crest White Strips, right? Believe it or not, took technology out of the home care business, brought it into oral care where we basically use the same substrate, changed the active ingredient, put peroxide on it, and that's what became White Strips, right? And went from a $700 to $1,000 opportunity to $49.95, the most expensive product that Procter had ever sold. But really understanding where was the market need, where was the opportunity, and then how could you bring the innovation to bear. One of the other things I shared with Steve was, if you go down a grocery aisle, go down the toothpaste aisle, it's miles and miles and miles of toothpaste. Like, how many different things do you need? It can be overwhelming, and we decided that we learned that the consumers were overwhelmed. They didn't know what to choose. We kept the aisle as big as it was, but we reduced the number of items that were there so people could more easily find what they needed, right? So really understanding what were the problems, big or small, and how do we think about that? So when I think about, coming over to healthcare, and this is a really, really small but consumer-driven insight, we created something called Advanced Immediate Care at Ohio State. So it was emergency room level care, but really in a urgent care environment. But because it was different than urgent care, we had to give it a very complicated, not particularly consumer-relevant name, Advanced Immediate Care. People had no idea what that was, right? It was different than something else, but weren't really quite sure. It was doing well, but we realized it could be doing so much better, and we simply went to the language that the consumer spoke, rebranded it as Advanced Urgent Care, and pretty much quadrupled the volume going through those outlets overnight. So I think sometimes we outsmart ourselves, or we try to outsmart ourselves and make it really complicated and not easy to navigate in environments where people are really anxious, when you go back to Steve's original question. So just some different kind of very basic logic things that I try to bring into the enterprise every day.
It's a great example. And the benefit of keeping it simple and using the language that's familiar. Charlotte, you've had a number of roles at Ochsner in the investment side and the innovation side, and Ochsner's known for really innovating the consumer experience in a lot of ways. Can you share one or two of those examples or some of the ingredients that has made Ochsner successful?
Yeah, absolutely, and appreciate the question, and also appreciate the Crest whitening strips. Yeah, I think that, from a consumer, we've been talking about consumerism in healthcare for a while. I haven't been in healthcare for that long, but it certainly has been pre-pandemic times. And so I think we probably all have a lot of examples of things that we've tried to do to learn from other industries and to bring that into healthcare. And I think across all of that, just, lesson learned is that you need to understand the need, you need to understand the problem, you have to design for it, but you also have to really help people get there and meet with them where they are. And when we're talking about digital health and we're talking about technology, not everyone's on the same page with that, and people might need help. And so being very cognizant of that, not only for our patients, but for our providers, for our admin staff, for our back office staff. And so I think that's a really important lesson. And so just to kind of highlight how we've done that at Ochsner, in one particular example, some folks have asked about our Ochsner digital medicine programs. Those are our RPM programs that were launched and piloted in 2014, and we've stuck with it, and we've served almost 50,000 patients. That's at Ochsner, as well as employers and payers that we started selling to in 2018, and actually hope to do a lot more with health systems in the coming years, so let me know if you want to talk about that, but just a little plug. But anyway, so for those programs, those are, today we all know what a digital health program looks like. You have connected devices, you have virtual care, et cetera. In 2014, that certainly wasn't the case. We launched those programs where patients it was first hypertension, then type 2 diabetes, and they had to have a smartphone, and they had to connect their new connected device to the smartphone that then somehow got into Epic. And so we realized that there was no way that we were going to be able to just trust that patients could figure that out. And 10 years ago, getting anything into Epic from the outside was super hard and a bit clunky. So we created what we called the O-bars, very much taking inspiration from Apple, of course, and making a very inviting space in our primary care clinics where patients could go and ask questions. And not only ask questions about just this burgeoning digital health world in general, but also get set up for these programs. So they could walk out of the doctor's office with kind of just newly being enrolled and then go see an O-bar technician and get their devices and get set up and take their first reading without ever leaving the institution. And that ended up being critical to the success of our programs. And we have O-bars across the system. We created a mobile O-bar at one point to go to those kind of outlying primary care clinics. And actually, we created programs for pregnancy as well as specialty care, and we created specially designed O-bars in those locations. So where all of our maternal care is, we have an O-bar specific for that program, for instance. But one thing that I think is really important is that needs change. And I was actually just talking to the team that leads O-bars, and post-pandemic, people know how to use their phones a lot more. Things have become a lot easier. Technology is better, et cetera. And so we know that a lot more people are able to just kind of do it themselves or use tech support. And the idea of patients going to the O-bar is way less relevant than it used to be. But there's still people we're missing. And so they're pivoting their model right now and thinking about meeting patients where they are. And they have our O-bar technicians actually doing digital literacy education in community settings and in alternative sites of care. And also they are doing a pilot where O-bar technicians are going to the bedside at discharge. And so when patients are getting enrolled right from discharge, they can leave the hospital, their caregivers understand the program too, and they're just sort of ready to go. So just also, making sure that we are adjusting following the need and adjusting what we're providing.
I have to say, when I was at Apple, that caught our attention, and I spent a lot of time with your colleagues in New Orleans because I was so impressed at what you had set up. And I'll just share a couple of things, I hope you don't mind, and I know things have evolved, but I was struck by the amount of attention to detail that went into the experience for hypertension first. I don't know how long it took the team, but well over a year to set it all up and all the back end so that the data just flowed seamlessly and the patient didn't have to do anything and the doctor didn't have to do anything. It was kind of going into workflows, and it was all managed by exception, and they had pharmacists and others managing the meds, so it was really thoughtful about that. And then I asked, so how did you then go from that to the next condition to pregnancy, and how hard was that? And the answer that I heard from the team was, it took us over a year to set up the first program, technically, it only took us a matter of a week or so to shift that over to other conditions because the pipes and the back end were almost identical. But all the hard work remained on the change management. When you go from one service line to the next line, you have to figure out what's different there. Really compelling. I have to say, like, it's inspired a lot of health systems around the world. There are places in Singapore to this day that copied the OBAR and have had similar successes. Rick, let me turn to you. As the CMIO at Sharp, you have a lot of firsthand experience with the demands that are placed on the clinical staff. And it can be all well and good to put in place some great consumer experiences, but sometimes that can impact the clinician experience. Many times it does. So how do you balance those, and what are some of the pitfalls to avoid?
Well, first off, I want to acknowledge the OBAR. I copied that at Sharp as soon as Rich Milani or somebody described it at a Health Management Academy meeting. And secondly, I want to remind everybody that Dr. John Noseworthy and I are fellow alumni of Dalhousie Medical School. I was a few years ahead of John, and he still owes me 3 discharge summaries when he was my resident in critical care. And as my 50th anniversary and reunion is coming up next week, and I will be going to the VG, I will bring back those summaries. About 20 years ago, Sharp had to reinvent itself. And one of the things that it came up with was something called the Sharp Experience, which I'm sure a lot of people in the room have heard of. It was an emphasis on getting the service end of your care correct. And our ex-CEO, Mike Murphy, Mike had a folder in his office about that thick of acknowledgments, congratulations, and thank yous from other hospital CEOs when a member of their family ended up at Sharp and they came to visit and couldn't get over the attention to detail on that side of the equation. Times change. And in trying to keep up with that, one must be careful about the old adage of over-promising and under-delivering. We are very recent, March of this year, Epic client. We drank the Kool-Aid about how easy it would be for people to message their doctor and, get a response. We had already had a really good experience with a patient-centered app, and it was working well, but again, we swallowed the Kool-Aid, and nowadays we are about 7,000 messages a week. Occasionally on a day, we get over 1,000 messages an hour. There's no possible way a PCP or a specialist can keep up with that. One of our Best Coast organizations, sister organizations, Sutter, had a similar experience, cost them $25 million so far to help correct that. That's something that I think the divide and conquer approach would help, but we really need digital tech. Probably, I was disappointed that 2 of my colleagues this morning thought that AI was overhyped. I don't think so. I think we're just scratching the surface with this little gem, and the sooner we can get it to actually improve things like the patient experience, where the digital experience is not thought through perhaps as well as it could have been, our bad, but we really need help in that regard.
Yeah, it's a great example. When I was at Apple, we'd obviously pay a lot of attention to the end-to-end experience. And one of the things I learned is that it is much better to take a single experience and close the entire loop all the way through and figure out every hurdle along the way than to just start and do little pieces of a bunch of different things. And that's what your story reminds me of, is I'm sure consumers loved the idea that they could now message their doctor. The doctors didn't, and there was no plan to address that, so it creates this expectation violation when the consumer doesn't get a response. So really a great example of thinking through the entire closed loop of the experience. Jennifer, I wanted to go back to you and just ask, briefly, we don't have a lot of time, but any one or two examples of customer experiences or early successes that you've had at OSU?
Yeah, I would say two pop to mind. One is that we have created what we call our My Health app, which sits kind of on top of or includes MyChart, but we've elevated the functionality of MyChart to be more, to try to address more of what the patient or the patient as a consumer might want to be able to receive kind of when they engage with that. So some of it is our health and discovery information, which is stories about what's going on. Others may be urgent care hours, but how do you, rather than all of these little Lego pieces, how do we integrate things and really elevate that? I think the other thing that's probably more, even more exciting is the all-in-one device effort that we've done, which really thinks about how do we almost consider the nurse as a consumer and bring together the tablet, the phone, the documentation into one place. This is something that the team's been working on. It predates me for over 6 years, 3 or 4 failures along the way, but knowing that at the end of the day, that really is ultimately what we're striving to do. How can we continue to learn from those failures along the way or learn from those mistakes and continue to drive forward? So we probably have now about 4,000, just over 4,000 devices deployed. It has helped us to take time per 12-hour shift down about 15 to 20 minutes of people spending time documenting, because it's just significantly more efficient. But it's like, what is that opportunity? How do we bring it together, and how do we continue to push it out? You know, and what's that vision for 5 or 10 years from now? There's no keyboard in the room, right? So the clinician, the practitioner is able to spend all of their time with that patient, and it just elevates the experience and improves the outcomes.
It's a great example. And I just want to build on a comment you just made, which was, I thought, very insightful. You know, at least in my own journeys, and you can tell me if this resonates, I see some places that are really good at thinking in a distant time horizon. They can dream up, they can think big, here's the end state experience we want to have, but don't really think about all the steps to get there. And others that are extremely practical, extremely tactical, and like, this is what we're working on right now, but not yet so clear about like, what is that true north or what's that vision? And I think what you described is like, how do you play effectively in both of those time horizons? Paint the picture of the experience you really wish you had, but don't go so pie in the sky that there's really no way to get there. And what are some meaningful things you can do tomorrow? So that was fantastic. Charlotte, let me turn back to you. As I mentioned earlier, Ochsner has been able to scale a lot of programs in the consumer experience space, and it's not easy, right? There's a lot of kind of ships crashed on those rocks of like single point solutions and proof of concepts that kind of fizzled out. How do you think about this sustaining kind of metrics or KPIs that keep people going and allow you to kind of scale over time?
Yeah, thanks for the question. I think that for us, your original question said something about ROI. Of course, ROI is important, and things need to be financially sustainable. But right now, when we're designing new innovations and care model redesign and all that kind of stuff, we're thinking about things that have to hit at least 2 of, or not all 3 of, patient experience, clinical outcomes, of course, but also the ease of practice, which we all know is so critical to everything we're doing. And so part of what our teams have done over the past couple years is we've actually been learning from tech-first industries, as healthcare probably should have been all along, and are thinking differently about the way that we measure, we develop our KPIs, and then also how we do design. And so we've built up a product management team, which is, that kind of true product management, something we hadn't had before, having UX designers and that type of thing, and are really concerned with usability. Which goes back a little bit what I was talking about with OBAR, but really kind of the how much effort does it take to get through these different experiences that we're providing to patients? What's the effectiveness of these experiences? And a way to sort of illustrate that for us right now that's really current is e-visits. Which we've all learned that people love to send messages, but that they are overwhelming folks, and they're not necessarily, appropriate for delivery of care. And so we've been really focused on bringing e-visits as a new access point to patients. And so we've been doing that, and we created the process, we made it work from a technical perspective, but then we realized people weren't using it, and we did a bunch of A/B testing and really applying design methodologies to try to improve that. And today, we actually, I think on Epic, we have the highest volume of e-visits in the country. I think 4,500 to 5,000 a month, and we have it in over 30 plus conditions. And I think one thing that the team is super proud of is that 70% of those messages are responded to within 2 hours.
Wow.
Which is obviously not only delivering on what the patient needs, but if that's happening, that it's working for the providers as well and care teams, and that's critical to any consumerism initiative. It has to work for everyone that's involved.
Truly impressive. Thank you. We only have a minute left. I have one last question for you, Rick, and I'll just start by saying, the motto in Silicon Valley is to move fast and break stuff, and the motto in healthcare is do no harm. How do those two things come together? And the specific question, Rick, is how do you balance innovating at scale with ensuring, safe and equitable deployment of innovative technologies?
You take an idea and you run it by as many people in your organization, friends and family, as you can, and get them to take it apart. And that is what Kelly Coe, my coworker at Sharp Ventures, and I try to do every week. And we've learned that from the folks in Aegis and the folks up in over in Chicago with Abundant Ventures, and it's, I think it's part of the secret sauce.
Fantastic. That's all the time we have. We probably could have spent the whole day on this topic, but thank you so much to the panelists.